Good afternoon. My name is Chloe Williams, and I'm an epidemiologist with the Lewis and Clark County Health Department here in Helena, Montana. I'm so grateful to be able to share time with you today to discuss a historical outbreak that is close to my heart in that it really helped to cultivate my interest in public health and epidemiology as a whole. Today we'll be discussing the historical outbreak of Ebola virus that occurred in Reston, Virginia in 1989. As a point of context, Reston is located around 30 minutes from the nation's capital in Washington, D.C. I personally grew up around an hour and a half from Reston and had the pleasure of reading The Hot Zone in high school, which chronicled this outbreak in Reston, Virginia, as well as the outbreak in Africa, which then really led to my interest in epidemiology and public health as a whole. So today, we will spend our time together defining the Ebola virus, which will include signs, symptoms, and mortality rates, as well as suspected country of origin. We will outline the background of the outbreak, how it occurred, through what vector, who initially discovered its arrival into the U.S. We will discover perceptions surrounding the Ebola virus from U.S. officials and initial plans for containment. We'll explore data utilized to assess outbreak risk to the general population and examine visual representations of data used to establish outbreak exposure trends. Lastly, we'll take some time to listen to lessons learned from this outbreak experience as well as other Ebola outbreaks throughout the world. Initially discovered in 1976 in parts of Central Africa, Ebola viruses are defined by their mostly fatal symptoms of hemorrhagic fever. Hemorrhagic fever is defined as caused by infectious diseases that damage the walls of blood vessels, causing leakage as well as decreasing blood clotting ability in the body. The ultimate result of hemorrhagic fever is internal bleeding in the body, which can be fatal. Signs and symptoms that can be attributed to Ebola include, but are not limited to, experiencing a fever, flu-like symptoms that include body aches, headaches, muscle or joint pain or discomfort, weakness and fatigue, loss of appetite, so no longer hungry, gastrointestinal symptoms such as stomach pain, diarrhea, and throwing up, and lastly, and as mentioned before, a calling card of Ebola virus, which is unexplained hemorrhaging, bruising, or bleeding. So how serious is the Ebola virus? The World Health Organization reports that average Ebola virus mortality rates are around 50%. They also report that past case fatality rates have varied from 25 to 90% dependent upon containment circumstances and overall responses to the outbreak. This percentage means that in each population, the average mortality rate for those who acquire Ebola virus is 50%, i.e., 50% of diagnosed individuals die from the virus. It's important to note that protocols for containment, including isolation, changing burial practices, and wearing PPE, which is personal protective equipment to protect healthcare providers and community members from bodily fluids, have immensely positively influenced transmission rates of Ebola virus in many countries. How is Ebola transmitted and where did it originate? The CDC reports that the most likely origin of Ebola virus is via contact with animals, specifically primates such as monkeys or fruit bats that ingest insects. These are also called zoonotic infections because they're passed from animals to humans. Ebola virus is generally spread through contact with bodily fluids, which include but are not limited to urine, saliva, sweat, blood, breast milk, and semen. It is important to note that in order for the virus to enter your body, it must enter through a mucous membrane such as the eyes, nose, or mouth, or through broken skin. Ebola can also be transmitted through secondary contact, which includes clothing, needles, or medical equipment that have been contaminated by the virus. So similar to same rules apply in a secondary transmittal in that the virus has to have an entry point of a mucous membrane or broken skin. Due to these methods of transmission, it is especially important that individuals working with people who've been exposed to or diagnosed with Ebola virus protect themselves using PPE or personal protective equipment. The Ebola virus has an incubation period of 2 to 21 days in which the exposed person will likely experience little to no symptoms. Individuals are not generally contagious until they begin to experience symptoms of Ebola. Ebola can be diagnosed through a blood test, which is also known as an RT-PCR, and we'll discuss the importance of this laboratory diagnosis later on in the presentation. The first cases of Ebola were discovered in current-day Democratic Republic of Congo and southern Sudan. Ebola virus outbreaks generally occur in sub-Saharan Africa. Now that we've taken some time to gain background knowledge on Ebola, its signs and symptoms, vectors, and methods of transmission, we'll return to Reston, Virginia to discuss the 1989 outbreak that occurred there. At a research lab in Reston, Virginia, a shipment of crab-eating macaque monkeys arrived from the Philippines and subsequently began dying at high rates. During this time, general perception surrounding Ebola was that it was a devastating virus that was confined to Africa, so the thought that it could be the mechanism behind the macaque's death was not top of mind. The initial diagnosis prior to testing of the macaque monkeys was hypothesized as simian hemorrhagic fever, which has similar symptomology to Ebola virus, but poses no risk to humans, only monkeys. Upon testing, it was discovered that the macaque monkeys had Ebola virus rather than simian hemorrhagic fever. Due to a perception of confined location, contingency plans surrounding possible Ebola exposure and handling of contaminated equipment in macaque monkeys was not considered prior to testing. So the monkeys were handled by handlers and others within the lab prior to the knowledge of a potentially deadly virus. And so initial testing demonstrated that the strain devastating the macaque monkeys was the deadliest version of Ebola, which is called Ebola Zaire. And at the time, Ebola Zaire had a mortality rate of roughly 90%. While all the macaque monkeys in one room of the lab were humanely euthanized, macaque monkeys in a separate room, who had no contact with the initial group of macaque monkeys, had somehow contracted the virus, which led to an overall fear of airborne exposure. And so the individuals who were testing the macaque monkeys and had euthanized the monkeys prior to, which was a federal health department, were especially concerned for potential airborne exposure, as the monkeys had never met one another, and the only way for them to expose one another would be through air ventilation. And the CDC defines airborne exposures as germs that are aerolized in tiny particles and can be spread through coughing, talking, sneezing, etc. So as you would imagine, highly contagious. Final plans for containment included all macaque monkeys in the lab being euthanized by Army officials, and all Army officials involved in the euthanization of the macaque monkeys wore hazmat-grade PPE and performed the euthanasia from a distance. For me personally, this causes quite an ethical dilemma. All of the veterinarians working on the outbreak, and there were many due to this being a zoonotic infection, attested to how sick the monkeys were and how it was the most humane approach for them. The methods for decontamination of the lab included bleaching, general sterilization, and the burning of formaldehyde crystals to ensure airborne decontamination. The CDC reported that while 4 individuals working in the facility acquired antibodies to the Ebola virus, none of them experienced symptoms. So basically, just to conclude the Ebola Reston outbreak, none of the humans who interacted with the macaque monkeys who had been exposed to and eventually diagnosed with Ebola virus ended up becoming symptomatic or being sick in any way. We're going to run through some methods used for testing for and containing Ebola virus. As mentioned earlier, Ebola can be diagnosed via a blood test, which will generally show infection 8 to 10 days following initial exposure when symptoms begin to arise. And just revisiting, the average incubation period is 2 to 21 days. However, symptoms can start appearing as early as 8 to 10 days. Following confirmation of Ebola, it was discovered during the 1976 outbreak in Africa that the best approach to containment was isolation of confirmed cases, infection control, utilization of personal protective gear, contact tracing, and the priority of reliable laboratory testing. As Ebola reston was isolated to one facility, it was a much smaller lift for officials in the U.S. to coordinate efforts to contain the disease and limit exposure as much as possible. So there are some important notes to consider. In many of the outbreaks in Africa, community cooperation, collaboration, and education was an exceptionally important part of containment efforts. It was important for officials assisting and supporting Ebola virus care to approach community leaders for help and community buy-in to create successful interventions. Much education surrounded use of personal protective equipment, hand hygiene, culturally sensitive and safe burial practices, and safer medical practices such as not reusing needles. It was also important for those supporting efforts to contain and treat Ebola patients to provide adequate medical supplies and PPE. So many of the places in Africa were pretty remote and did not have access to the same resources that we may have in the United States, even in remote areas. And so when teams go to Africa for Ebola, because it still does pop up as outbreaks to this day, they are very aware of the need to provide PPE and different medical equipment to help with this outbreak. So we're going to take a second to do a bit of an outbreak investigation breakdown, starting with identification of the disease. So Ebola diagnoses can be established through a combination of exposure history, signs and symptoms, and a blood test for official confirmation. Surveillance methods used in Ebola breakouts are generally termed community-based surveillance, which relies on community members to report health events occurring within their community. So these are ideal in communities that have populations who may or may not have access to medical facilities, i.e. living in remote areas and not being able to get to medical care in a timely fashion. However, the Ebola reston outbreak utilized more of a facility-based surveillance due to the isolated nature of the exposure and ability to acquire all needed information from both the deceased macaques as well as handlers initially exposed to the virus. Continuing our outbreak investigation breakdown, we're going to discuss some data collection techniques. So due to the emergent and relatively unknown nature of the Ebola reston exposure, data collected included blood, tissue, and organ samples from confirmed cases in the macaques, as well as blood testing from exposed individuals to check for current infection and then Ebola antibodies, basically to check for the body's resistance to Ebola, meaning the person was infected, but they did not become symptomatic. Signs and symptoms were also documented in exposed macaques and exposed humans. Challenges faced by investigators included very little knowledge surrounding Ebola virus, which included ways of transmission and having to contain the outbreak as quickly and safely as possible in a densely populated area, with overall concern of exposure for officials working on the case. So I thought it would be an interesting exercise to compare the 1989 Ebola reston outbreak to the recent COVID-19 pandemic. And some similarities between the two include similarities between testing and containment, which included collecting signs and symptoms, the use of contact tracing, laboratory testing, and some differences included the type of laboratory testing, which for COVID-19 included nasopharyngeal mucus testing versus blood testing that occurs in Ebola tests. Signs and symptoms of both can begin with flu-like symptomology. However, COVID-19 has more respiratory symptoms, and Ebola has nausea, vomiting, and hemorrhaging. Over time, the importance of personal protective equipment for medical personnel and the public have aided in significant efforts to isolate exposures, even in densely populated areas. The response for both also brings into question the intentionality and importance of community buy-in when coordinating interventions for disease outbreaks. I wanted to provide the class with an Ebola epi curve. However, they don't have one specific to Ebola Reston, so I used a more recent epi curve from 2014 to 2015 in Guinea and Sierra Leone. And an epi curve is a type of graph that displays history on onset of illness among cases associated with an outbreak. And they allow epidemiologists to determine trends, patterns of spread, and exposure periods. So as I mentioned before, I was unable to locate a visual representation of an epi curve for Ebola Reston. I found this one to be exceptionally interesting because it is a very typical epi curve. So this epi curve provides an example of what they generally look like, but also conveys the high rate of transmission that Ebola had during the time period in the community. So between 2014 and 2015, you're able to see the number of confirmed cases between Sierra Leone and Guinea and how those basically reached a peak and then came back down over time. Finally, we're going to discuss some lessons learned from the Ebola Reston 1989 outbreak. And, responses to Ebola outbreaks have been evolving since its initial discovery in 1976. And some key takeaways include timely dissemination of information, which is sharing of information, especially to the public, so that they are aware of what is going on, rapid laboratory testing, immediate utilization of contact tracing and isolation protocols, established protocols through the CDC's Emergency Operations Center, which is also called the EOC. And these are deployed to affected countries, and that's for Ebola or any other kind of infectious disease that has created a large outbreak. Utilization and provision of PPE for medical professionals and community members. And one of my favorite highlights, because I think one of the most important parts of epidemiological work is working with community members. And community considerations include culturally sensitive education on disease transmission, garnering community buy-in, which means the community believes in what you're doing and is willing to go forward with protocols, advice, recommendations from the health department, and establishing trust and partnership with community leaders. It's really important to have trust and partnerships with community leaders because they influence the community in such a positive way. So Ebola Reston is unique in that it was a very isolated case of an outbreak and only affected the macaques in the Reston lab. However, by using the same protocols for isolation, decontamination, and surveillance of individuals exposed, a potential catastrophic outbreak was mitigated. And the last couple pages that I have are some references that you're more than welcome to look into. I thank you all so much for allowing me to spend time with you today. I hope you have a wonderful day.